He joined our pediatric residency program. During residency, Dr. Zawadi has been pretty active. He has submitted multiple case reports, couple of them pertaining complications from COVID-19. He is also involved in QI project with our NICU folks on awareness, recognition, evaluation of hypoglycemia in NICU patients who are greater than 48 hours of age. I'm extremely excited to share with you all that Dr. Al-Zabadi has planning to be a pediatric pulmonologist at some point. And that was primary reason for him to pick this topic, which is COVID-19 and pediatric pulmonology, current knowledge and emerging insight. So please welcome Dr. Al-Zabadi.
Thank you guys so much. Today we'll be talking about a few different things. We'll start with talking about the main pathophysiology of COVID-19, why it mainly affects and causes ARDS in the lungs. We'll talk about the association of asthma and developing asthma from or following an acute infection of COVID-19. We'll talk about imaging and how to limit radiation exposure of chest X-rays and CT scans in the acute and chronic periods of infection of COVID-19. We'll also talk about post-COVID-19 syndrome and how to mitigate that syndrome. Starting off, disclosures. I have no disclosures at this point. I will be discussing medications and treatments for the sole purpose of education, but not as endorsements. Starting off, I wanted just to briefly share the timeline of COVID-19. COVID-19 started initially in 2019 in China and declared as a pandemic in March of 2020. Since then, we had multiple variants of COVID-19. The Omicron variant was identified in South Africa. Hence the importance of updating vaccines, especially on our high-risk patients with chronic lung disease. We did also see a shift in healthcare pre and post COVID-19. So pre-COVID-19, our healthcare system mainly focused on approaches on like single patient approach. Telemedicine was underutilized, but after the COVID-19 pandemic, we saw a shift in that more utilization of that telemedicine, a shift and rapid utilization and updates in vaccination. So the healthcare system tried to rapidly improve our vaccination guidelines to rapidly kind of just make vaccines available instead of taking years and just doing that process much more quicker. Coronavirus disease is mainly ARDS, a severe ARDS from the lungs, acute respiratory distress syndrome. Literature just say that it is less severe in children than in adult population. Half the children are asymptomatic and therefore not diagnosed. Only 2 to 3% of those diagnosed end up being hospitalized, with some concern about MIS-C. From 52 articles, included roughly around 1,300 articles in total, a total of 3,300 patients with COVID were included. Of all of those cases, just around 27% had moderate illness, with only 4 to 9% really, 162 cases were severe. Of those, only 47 had CT scan findings suggestive of ARDS with that ground glass opacity, thus really highlighting that the majority of cases of pediatric COVID are really asymptomatic to mild to moderate, with just the minority of them needing that extra level support. Moving on to pathophysiology of COVID, why does it affect mainly ARDS and the lungs, and why does it cause severe ARDS? We see COVID-19, it does bind the ACE2 receptor competitively in the lung, and that's mainly the driver of the infectivity of the COVID-19 virus. And what it does, we can see here, it does interplay with a couple of different systems. So the ACE2 receptor, when it binds in its natural course, it like our angiotensin causes like vasodilation, anti-inflammatory effects, anti-fibrotic effects, and it also has a balance with our RAS system, like renin aldosterone angiotensin system or bradykinin system. All of those systems are important for blood pressure support, salt wasting or salt balance in our bodies, and inflammation. But when COVID-19 infects and just shifts the balance into the other direction, our angiotensin levels or activity underexpresses from the lungs, hence shifting the balance to vasoconstriction, fibrosis, edema, thus inhibiting the activity of surfactant and leading to severe ARDS picture. Tissues that express ACE2 really kind of drive what we think about as the symptoms of COVID-19, mainly ARDS, as we said. Surfactant is from alveolar type 2 cells or pneumocytes type 2. So it makes sense that the majority of our symptoms are going to be ARDS. Bronchial systems like bronchiolitis or bronchitis in our younger kiddos, endothelial cells, taste changes, olfactory changes, hence we do see some of that expression of ACE2 in our tongue epithelial cells. We also did see a lot of patients having encephalitis type picture, meningitis, and we did see ACE2 expression in neurons and glia, which we also saw in MRI changes in those patients who did report meningitis or encephalitis type picture. So it also can be expressed in our neurons as well. Complications with any viral illness, we do see, and we are just looking for dehydration, like managing our patients with any viral, bacterial, or fungal illness. But our COVID-19 patients, majority of them will have ARDS. Pneumonia complication is less likely, but we see it quite often. Septic shock, encephalitis, we don't see as often in our kiddos. But again, we do have that multi-system inflammatory syndrome of childhood that has been reported in literature and we should be cognizant of. Now, mainly focusing on ARDS. Why is it more severe in patients with COVID? As we said, AT2 cells synthesize our pulmonary surfactant, which mainly is the effect during that cytokine storm, oxidative stress, increasing vascular permeability, which leads to also lymphocytic infiltration. All of that cascade drives our ARDS picture to be really more severe in COVID-19. We also see that being more predominant in our patients with cardiovascular comorbidities, our diabetic patients and patients with higher BMI, because of all those systems that we talked about, our renin aldosterone and angiotensin system, our bradykinin system, because all of those kind of just affect the balance of salt, affect the balance of how our smooth muscles react to all of those comorbidities and complications. Focusing mainly on why we see just severe hypoxemia in our patients with COVID-19. So we see lower VQ regions by just shunting and hypoxemic vasoconstriction, with high VQ regions due to immune microthrombus formation in our lung tissue, thus making the shunting much more prominent in patients with ARDS due to COVID versus ARDS due to other pulmonary reasons like other viruses or other bacterial illnesses. And we see it much more prominently in our adult population, but we can see this as well in pediatric patients. We do see fibrosis as well. A lot of our fibrosis complications are reported in adult literature, but we can see it in pediatrics. Now, medications to consider in severe COVID-19 is in a case-by-case basis, really. Corticosteroids, mainly dexamethasone, is utilized in the hospital settings. And we know in the COVID guidelines, if you have an increase in oxygen needs and requirements especially for our chronic lung disease kiddos, if they're at baseline on oxygen, really we don't choose to start like remdesivir or corticosteroids. But if the kid was not on oxygen, requiring a lot of oxygen, especially high flow, we will use corticosteroids. Dexamethasone provides adequate steroid exposure, but for our kiddos who really you are worried that they have adrenal insufficiency, you're worried that they are just at baseline at that higher risk. They are in shock. They're not improving with your catecholamines like epi nor epi. Then you should really consider methylprednisone. Dexamethasone does not provide adequate exposure in those settings. And again, if that patient is requiring mechanical ventilation, ECMO, or even high flow, you should consider like monoclonal antibody therapy as well. We do see new research for monoclonal antibody that's based on the spike M protein, and that's mainly being studied in mice at this point, to really aiming at decreasing the infectivity and the competitive binding of that spike protein to the ACE2 receptor in the lungs. We did see in studies that administering soluble ACE2 in plasma in mice did show an increase in ACE2 activity, which led to kind of vasodilation, decrease in infectivity. And it was also like shown to be protective in prophylaxis in those kind of cases as well in mice, to prophylactic, like in cases of exposure, to decrease infectivity and later on the acute phases of COVID-19. But those, however, did not show any activity in heart or renal systems. Managing COVID-19 in high-risk patients. Now, who are our high-risk patients? Asthma, if it's really well controlled, is one of the questions that we'll later answer in this presentation as well. Chronic lung disease, bronchopulmonary dysplasia, immunosuppressed patients, obese patients are classified as high risk when it comes to COVID, and I'll talk about later in this presentation as well. Remdesivir is a consideration for all those patients. It is approved for 20 days patients and older, weighing 7 pounds with a positive test of COVID-19. Usually mild to moderate patients with high risk illnesses is a consideration, but in mild to moderate cases with really none of these complications or risks, you should not be needing remdesivir really. Again, I talked about lung fibrosis as a potential complication. In our adult population, we see a third of our patients having fibrosis. We did see in literature a 10-month-old who was admitted in shock, respiratory failure. Initial imaging did show bilateral pneumonia. At the 2-week mark, they did do a CT scan that showed bilateral lower lung fibrosis. In that particular case, they did do a much more aggressive regimen targeting that inflammation with steroids, followed by a taper, remdesivir, azathioprine, and azithromycin, all like really aimed at just decreasing that inflammation in the acute phase. In that particular case, 6 weeks after the initial inflammation, there was marked improvement of that fibrosis, with almost the majority of those lung findings being reversed. And that case report really highlighted the use of azathioprine in lung fibrosis in pediatric patients. Now, a lot of theories were laid out on why our pediatric population was at a lower risk of acute or severe acute COVID-19 rather than adult patients. One of them was the good regenerative capacity that could explain the less severity and early recovery, but other ones was higher frequency of like motility of the cilia and the epithelial cells in the bronchial tree and the pulmonary system. Hence why we always in our well child checks just talk about smoke exposure, just minimizing that other risk factors. And one other really interesting theory that I saw is greater upper airway resistance compared to adults, which really we see more bronchitis with COVID-19 in pediatric patients rather than pneumonia, which really supports that third theory. And I thought that was really interesting in our pediatric population. I thought that was really interesting and funny. In our chronic lung disease patients, you have to just make sure you're counseling patients and just in recognizing that they are high risk and just providing them with ways to make sure that they don't catch COVID-19, whether that be vaccination, whether that be just wearing face masks, just being cognizant that they are high risk if they're not well controlled, whether it's asthma or any other complication. Moving to imaging, we did talk a little bit about a couple of rounds ago when Megan did her talk about limiting radiation exposure. It is also true in COVID-19. Kiddos can be very sick, and we have to talk about ways to limit radiation exposure. In a meta-analysis, including just over 1,000 patients, they did kind of look at CT manifestations that could potentially be used for early identification for COVID-19. Unfortunately, there was a lot of limitations, including no clinical correlation between how sick the patient was and how that correlated with CT scan findings. In another study, they did see like 4 to 1 patients with COVID-19 pneumonia were included. 3 of them with severe disease. None of them were mechanically ventilated at any point during hospitalization. And they looked at persistent symptoms being reported in 7 patients. And they did try to utilize lung ultrasounds instead of CT scans. Now, lung ultrasounds is gaining a lot of really new momentum in research where it's being utilized in pulmonary embolism, pneumonias, pleural effusions, and many other pulmonary pathologies. In this study, they did not see any significant changes in pulmonary function testing, but they did see abnormalities in lung ultrasounds, which were improved later in follow-up. Here we can see the lung ultrasounds and what they saw as normal, baseline, or abnormal. In the A and B pictures, you can see really what they described as A lines or normal lung findings. A lines were described as horizontal lines that are aligning with the pleura without any pleural irregularities, thickening, or just fibrotic changes. In C and D, you can see pleura thickening over here, or like on the red line, you can see the pleura is just irregular right now, starting to have vertical changes associated with it. And they describe those B lines as significant if there are 3 or more in one single rib space. They looked at also, one other study looked at abnormal chest x-ray findings, and they classified patients as mild, moderate, or severe based on their clinical complications, whether patients had pleural effusions, pneumothorax, cardiomegaly, and other findings. Unfortunately, it did not, the findings from this study did not say, they did not recommend any imaging for mild to moderate disease. However, they did find it statistically significant if the patient has an atypical process, much higher oxygen requirement, and if you're worried about a severe complication like empyema or cardiac issues, that you go ahead and do x-rays or CT scans, and that was statistically significant. And what they looked at, the severity score, they mainly looked at CRP, inflammatory markers, leukocyte count, GFR, age as the main drivers for the severity score. What did they identify as post-COVID-19 syndrome? They said at least 3 months of symptoms of persistent dyspnea or exercise-induced dyspnea with cough and exercise intolerance. And that was reported really as persistent dyspnea in 96% of patients who report post-COVID-19 symptoms. In a study looking at MRI findings, whether morphologic or functional changes at low field MRI, they did find pathological differences between infected or post-COVID infected patients and healthy controls. Although pulmonary function testing or pulmonary reserve was normal, they did see a VQ match. The VQ match was lower in patients with post-COVID-19 rather than never infected controls. And this is what they found. They stratified it based on healthy or post-COVID infected less than 180 days, 180 to 360 days, and over a year. And it was statistically significant in each one of the different subsets that the MRI changes were seen, and the VQ match was also lowered in all of those subsets. In an Italian study looking at patients, and they wanted to mainly answer the question whether a higher BMI was related to really more symptoms and complications of COVID-19. And what they found and what they looked at is fever in and by itself, fever with one other symptom, fever with hospitalization. And they did find that patients with a higher BMI than 85th percentile were found to have much more like fever plus one other symptom or significant finding from COVID-19. And they also looked at lung ultrasound findings, not just clinical correlation as well. And they also found what we talked about, those irregularities in the pleural lines or B lines were much more prominent in those patients with a higher BMI. And what we talked about initially comes into perspective here, that the cardiovascular comorbidities, obesity, diabetes, it all comes into play when looking at the patient in general as a whole, not just the lung process causing ARDS. I also wanted to talk about competitive sports and return to competitive sports after COVID-19 infection. All the literature does say that it's on a case-by-case basis. If the patient really did not suffer that severely from COVID-19, you can just evaluate them in general practice clinic and make sure that they are tolerating everything well. But a study was done just to make sure that those patients with more severe presentations, did we need to do any other testing from a cardiac standpoint or a pulmonary standpoint? And they excluded any patient that were not cooperating with their test, or patients with a negative test, or still having symptoms of fever, cough, and other viral illnesses that could limit that validity of that study. They looked at the forced vital capacity. They looked at forced expiratory volume in 1 second. They looked at the diffusion of carbon monoxide as predicted values of anything more than 80% as normal, less than 80% abnormal. And what they found was mild COVID infections do not pose any risk of developing cardiopulmonary illnesses, even under high physical stress. But children should still continue to be assessed, specifically those with more complications requiring PICU admissions or MISC. In one study, it was found that 2/3 of patients had exercise intolerance doing the 6-minute walk test. But the limitation of this study, as any other pediatric study really, is the small sample size. When we look at it here, there was a clinical trial looking at 20 patients suffering from post-COVID or struggling with their sports activity, and 28 healthy controls. They did find that the total sports activity time was lower, and it was statistically significant by about 150 seconds in the post-COVID infected group. They also looked at elimination of or oxygen peak elimination curves in both those groups. And it was statistically significant that it was lower in the acute post-COVID-19 group rather than healthy controls. But they did also note that all of those patients had reserved or had no alterations in their pulmonary reserve or FiO2. They also looked at the period of rest in COVID-19 patients and in relation to the oxygen elimination curve. And they found it is statistically significant and was lower in patients suffering from COVID-19, even at the 3-week mark, suggesting that a chronic element could still be there and would still be chronically there for an inflammation standpoint that would need time to resolve. But the fact that there was no statistical significance between other pulmonary variables like the peak oxygen elimination, even at 1 second, the breathing reserve, breathing frequency between the two groups really did not make a ton of sense to just say it's pulmonary in nature, because pulmonary function testing was normal. So what really drove that exertional dyspnea was still a question, and they wanted to do just other testing in other areas. So other theories that everyone looked at was dysfunctional breathing as a marker of ventilatory efficiency. And it was found to be equivalent to like the oxygen elimination slope and the carbon dioxide elimination slopes. Altered pulmonary diffusion capacity, VQ mismatch, and hyperventilation were all reported in literature and documented in COVID-19 survivors. But whether that's the case in our pediatric population is still a question. They also did cardiac testing, looking at chronotropic function, supply and oxygen metabolism, and peripheral function as well. In adult population, the evidence does say that a lot of the patients did display a decrease in chronotropic function or a decrease in heart rate, whether that was due to muscular deconditioning because of the COVID-19 infection or a beta blocker insensitivity was a question that was not answered in adult studies. But none of our pediatric patients in any of the studies that I looked at displayed any change in chronotropic function, thus really making it less likely to be a cardiac issue at this point. And none of the studies really said that there was any evidence to suggest the supply or oxygen metabolism differences in our pediatric population between healthy controls and post-COVID-19. A lot of it did say, though, that the majority of the patients who did testing really reported fatigue as the major driver of them stopping their testing early. So whether it is just muscular deconditioning was the main point that they were trying to allude to in the majority of those studies. So whether it's pulmonary, it's we also talked about like the oxygen, the VQ mismatch, some inflammation or deconditioning were all theories, but so far nothing that's affecting the heart. I also wanted to touch base on the development of asthma after COVID-19. A study published by the AAP looked at whether COVID-19 is a modifiable risk factor for developing asthma. And we already know that a lot of viral illnesses predispose our kids to develop early onset childhood asthma, like rhinovirus and RSV being the main two drivers of that. Now, we did know that severe ARDS is an infection, or lower respiratory tract infections can be caused by COVID-19, but little was known about COVID-19's influence in the development of asthma. This was a study looking at a cohort of 27,000 pediatric patients and whether that COVID-19 predisposed them to asthma or not. What they reinforced in this study is the correlation between allergies and asthma. However, it did not show any relevance or any association between COVID-19 and asthma. Whether that's still the case or applicable in real life was the question, because the follow-up time was not that long. So whether this is good news that's not related to COVID-19, or is it just not enough follow-up, was also a question that was unanswered by the study. Now, I did find some adult data to suggest a correlation between asthma after COVID-19 infection, and this data was not related to any allergic response. These are 6 patients from the adult population. All did not have asthma. None of them has had atopic differences, and all of them improved in the bronchodilator test, and all of them improved subsequently with inhaled corticosteroids. All of them were normal before COVID-19, or from like an asthma standpoint, none of them did have it. But this study did show that the driver of their asthma was not allergic in nature, so it's not a typical asthma presentation, and it did suggest a T2 mediated response to their asthma rather than the typical allergic response. So, but again, there are only 6 patients. Whether that's generalizable also to our pediatric population is still pretty much a question. But having this in literature does make us wonder that should this be an area that we should look at as well. Asthma exacerbation, as we know, especially in the hospital right now with flu A, asthma exacerbation accounts for like 80% of it is a viral trigger from RSV, rhinovirus, influenza A or B. So early on, everyone just sort of assumed that COVID-19 would carry a similar risk. One study showed that the children with previous mild to moderate asthma experienced a chronic worsening in their asthma after COVID-19. Another study observed that the rise of asthma exacerbation after COVID-19 lockdown was predominantly in children less than 5 years old, but did not have that significant difference as in children older than that age. I also wanted to talk about inhaled corticosteroid use and asthma, because the main infectivity, like the mode of infection of COVID-19, as we said, is the ACE2 receptor. So the question early on was, using steroids, does it inhibit the immune response in the lungs, and does that make our kids more susceptible to carrying COVID or getting more sick from COVID? It is unknown whether inhaled corticosteroids at this point alters the susceptibility of COVID-19 or its binding to the ACE2 receptor. But a meta-analysis of just over 11,000 patients does not support an increased risk of pulmonary infections in general, not just COVID-19. So the recommendation is still to continue to use your inhaled corticosteroid. And also, just whenever you see your primary care provider, your pulmonologist, just walk through the correct way of using inhaled corticosteroids, updating their asthma action plan, and making sure that they're not high risk and they're adherent to their own asthma therapy. We also wanted to answer whether biologics and COVID pose a threat, because as we know, biologics can also alter our immune mounting, like how our body acts when infected to certain infections. So it is recommended, based on the studies that we have so far, to remain on biologics. However, there are a few other exceptions, and that's solely on a case-by-case basis after discussing the case with allergy, immunology, and the pulmonology team, because certain patients would need to stop it for other reasons, not the COVID-19 infection. But the American Academy of Allergy, Asthma, and Immunology notes no evidence to support an immune impaired response to COVID-19 with biologic use. Now, asthma exacerbations and the vaccine, we always have that discussion with patients, whether in Gen P's clinic or the hospital. Is my kid going to be at a high risk of developing asthma or developing any other illness with the vaccine? And that's always something I feel like we talk about during our well child checks. A study by the Italian Society of Pediatric Allergy and Immunology classified children with uncontrolled asthma as medium risk for vaccination, thus recommending use, like recommending vaccines. In other study assessing the severity of vaccination, there were serious events seen, so recommendation is still to vaccinate. Now, in terms of just telling families, parents, and our patients, now side effects do exist in literature. I did find a couple of them to the more severe side of things. A 29-year-old that suffered a severe exacerbation requiring an IL-5 blocker after the Pfizer vaccine, and then a 39-year-old who suffered a cardiopulmonary arrest after the Moderna vaccine. But even those being in literature, it did not provide enough evidence to support not vaccinating children. So the CDC still recommends vaccinating all children for the COVID vaccine, especially our high-risk population. And what do you guys think in terms of updating vaccines for COVID every year, especially for families and parents who are like, we just got the COVID vaccine last year, do we still need to update it? Do we think it is important to update? Families, I guess, especially in Gen Peds clinic, ask me this question all the time. But if the patient is high risk, if they have BPD, if they have asthma, then I would really advocate strongly for the vaccine. If they're at lower risk, I would still advocate as any other patient because it's still important and would make them less sick if they get it eventually. And it's important to still update those vaccines every year. I found this very funny. What doesn't kill you mutates and tries again, especially with the Omicron variant, that a lot of kids got really sick from that variant when it got introduced, like I think in 2020. So just making sure you counsel your patients. Also wanted to talk about our high-risk patients, patients with chronic lung disease. A study looked at multiple different things in those patients. In COVID-19 course, they usually found that it's mild, but the study did not specify because obviously our high-risk patients or those with chronic lung disease, they're usually well plugged in with our subspecialists. They have a plan, whether in complex care, whether with pulmonology. So whether the reason for that milder course was just because they're on top of their medications, or was it just underreported, was not well understood in that study, but it was a possibility. But it's a possible, it can be pretty severe if it's not, or if it's poorly controlled. Possible protective factors, they talked about T2 inflammation in asthma. So one thing that was really interesting that I saw in our asthma patients, because they have higher IgE levels, they did see an under or an overexpression or of ACE2 receptors. Thus, our ACE system goes to like vasodilation and decrease inflammation cascade. So they did actually see that our patients who have asthma are at much less risk of developing more severe COVID because of that reason, which I found was really interesting. Healthcare services, again, as I said, utilization of telehealth, telemedicine is really important for those kids. And then the psychological impact is really something that I wanted to talk about today. After the COVID-19 hit with a lot of lockdown, being a driver for mental health issues, we really need to be cognizant of our chronic lung disease patients, because those kids are usually at baseline not as active in sports as our healthy kiddos. They are not as keen on going around because they just don't feel well. They have a lot of restrictions. So just making sure that you're taking that into account as a psychological factor, because those kids can have more negative impact if you tell them you really need to stop doing this, or you need to lock yourself for like a week or 2 weeks. They're already doing that at baseline. So to increase the restrictions, you have to do that with a grain of salt with just managing their mental health in general. How can chronic lung disease affect the COVID-19 infection itself? Again, as I said, it's all about how the family and the patient's attitude towards their respiratory infection prevention. Are they vaccinating? Are they making sure they're like, if someone is sick, I need to know that I should probably keep my distance, wear a face mask, wash my hands. They did talk about going to work or not. Now we're far away from the height of the illness, I would say. So at this point, it's not a recommendation, but if a patient is a high risk and we know school has like a really kind of bad COVID outbreak, it's a consideration whether the kid should like just take a couple of days away from school to avoid them being really sick. Maintenance therapy, ICS, biologics, and as we said, the role of allergic inflammation and ACE2 expression. Mental health during the pandemic. Now, this was a study of just about 1,000 patients. The limitation of this study was all of them were self-reports. So with any self-reported study, you need that extra level of a psychiatrist or like a therapist to really analyze the data and talk to those children and analyze this. But majority of them did report more irritability, sleeping issues, headaches, And in the AAP, they did publish an article with the majority of our kids after COVID lockdown suffering from ADHD, anxiety-related illnesses. So really making sure that we're talking about mental health and normalizing that discussion and making sure our kids have that support system. Especially in children with chronic lung disease. Now, a meta-analysis of 30 studies summarized the evidence of a link between mental health and digital media use. We always know that in school, they're utilizing more like iPads or digital learning techniques. Seeing that balance is always important. You don't want the kid to kind of miss out on important schoolwork, but we know that non-work or non-school related media use can cause negative side effects for mental health. So the recommendation was based on social media is capable of reducing feeling of loneliness. The general passive use is still not recommended. We also have to talk about social determinants of health. As we do in our well child checks, we already know that malnutrition is linked to adverse effects on child's physical and mental health, psychological issues. It can lead to a lower immune response. Now, those risks are even higher in our patients with chronic illnesses in general, whether that be asthma, diabetes, or other things. Because we know if you're struggling to put food on the table, then probably compliance with medications not great, or it's something that you have to be cognizant of. So those kids are always at high risk of a more severe illness course. So just asking those questions and making sure you're screening for just nutrition, food intake, high risk social situations as part of your well child check. Reducing COVID-19 transmission. They also talked about using a metered dose inhaler with a valve as opposed to just an albuterol nebulizer machine, because they did say that would decrease the aerosolization of the COVID-19, thus decreasing its acute infection or its mode of transfer. But again, if the kid is on the younger side, not really tolerating that, then obviously you need to give them their medication to make them feel better. But in terms of just decreasing the mode of transfer, then the recommendation is to use an MDI instead. So take-home points in general, I really wanted to kind of talk about just how COVID-19 makes its way and causes severe ARDS, talking about obesity, managing other comorbidities, cardiovascular issues, talking about lung imaging in general. In our kids, if you have a way to decrease their radiation exposure, go ahead and do it. There's much more data to support lung ultrasounds being utilized now than a CT scan. So if you can do that reliably, especially if your kid is in the PICU, you're having to do multiple tests to make sure that they're doing better, just consider doing ultrasounds instead of serial chest x-rays in those kids. Neither asthma nor atopy have been associated with a severe risk of major COVID or lung alterations. Vaccines are still recommended, especially for our high-risk population. And then just continue to use your asthma medication. Biologics, inhaled corticosteroids are always important, especially for our COVID-19 or chronic lung disease patients. Yeah, those are my references, and thank you guys so much. Any questions?
Great talk. I was wondering if in your review you had seen, what is I'm sure there've been follow-up studies and I haven't paid attention. I'm sorry if everybody knows this and I don't know this, but how long does the antibody last once you've been vaccinated on average? And is there a role for antibody screening or testing in really high kids to guide vaccination, or what's evolving in that role or in that area?
Yeah, in terms of how long does it stay, I would have to look at each specific vaccine in general and what their recommendations are, whether Pfizer has different recommendations. I know the timelines for vaccinations in general. But I think a lot of it is also just like influenza, whether it's a new strain that you just have to update it every year is also a consideration. But in terms of just your like first question, whether like how long does it stay in the system? I don't know. I want to say it's around 9 to 12 months from our previous information, but from the new information from the Pfizer or Moderna vaccines, I really don't know.
You're asking about post-COVID illness or
I know there's
post-vaccination?
a difference, but what I'm
Yes.
talking about is post-vaccination, like is there an emerging recommendation for how often you vaccinate for your high-risk kids, or are there people looking at antibodies to see, or
Just I can tell
their
about-
guidance?
Yeah, it's once a year, at least I can tell about
Yeah.
our practice in, means we are recommending, especially our very high risk population, yes.
Yeah.
Asthma becomes a broad category.
Right.
That's like kind of a start on mild to moderate to severe. That is, especially when it's like mild to moderate also changes over months, which season you are and whatnot. Apart from very high risk population, we're not, we're asking them, but not proactively pushing for it, if that helps.
It's not on the routine
Yeah.
vaccination schedule.
But I do
But-
know this year, which vaccine came back with a newer strain, is then we have restarted talking about it.
Okay,
Because it has a different strain, which was not before. And with the, more like having it 2 peaks already lately, we have started again talking about it.
We do know that after COVID illness, you should wait about. Part of that is just to avoid leaving your immune system. Saw the illness, so you want to respond. Something that about 3 months after you have good antibody. And so we do know that if someone just had a COVID illness, wait to get that. About 3 months. And then to the question of how long do our antibodies last, it's estimate 6 months, 12 months, it's hard to say. And in terms of the decision of how often should we vaccinate children, right now it's on our schedule for once a year because it's hard enough to convince people to believe in that as part of the practicality of it. So they don't anticipate people looking at antibody levels and considering a twice a year immunization. One, because so many people reject the COVID vaccine, as many of us have experienced, it's very polarizing vaccine, and if people decided not to, it's very hard to them to even get it once. And then also because like the flu, it changes every year, so by the time they manufacture a new vaccine, takes about a year really to do all that, get it lined up and supply it. So I anticipate it'll still be a year's recommendation.
I think you could have talked more about the heart.
This is not the hard this time.
It's not the hard, right?
In kids.
During COVID, we were getting killed with
Yes.
patients that primary care providers see a kid, had COVID, wants to play sports and asymptomatic, and they still send them to us. In the whole spectrum. And especially early on, there were no guidelines. We were just making it up. And it's like Anna says in Frozen 2, just do the next right thing, right? And that's what we were doing. Guidelines got more helpful, but children, when they were having respiratory symptoms, send them the cards first. And then we go, it's not the heart, and shoot them over to you guys, which they should have got in the first place.
With this evidence, now we have to ask ourselves, is this just like exercise intolerance because of deconditioning, or just having like feeling down or just anxious, and that mental health part of it? Because there was a lot of overlap in that AAP study.
They were told to hide in the basement for months and then go play sports.
Yeah.
What makes their troponin levels bump,
Inflammation.
and just from inflammation?
I mean, COVID is a great example of, it's a respiratory virus, lastly. It can affect the heart, it can affect the gut, the kidneys, the brain. It's about, and most of the world, we've seen that forever, like a typical rhinovirus. Kids in the hospital for that, and they start having a bunch of ectopy. And then the virus goes away and it goes away. I mean, there's information that goes on that most of us don't even think about.
Just remind me, do you get a lot of reference still? Like we have a lot of patients post-COVID fatigue. Whether they're adolescent, they're always fatigued either way, but
Yeah.
question is, can we blame something else beyond that? And
Yeah, that's not the hard. No, and we get a lot of that too. Fortunately, less now, the long, the people, it was fashionable actually to have long haul COVID. And just, you could tell people talking to pride about it, because the parents, instead of talking about their kid. But it's a thing, if there was damage done, say to the heart, like decreased function or a lot of activity, and then we consider that person to have had myocarditis and we treat that like we would any other myocarditis.
yeah, one thing I would agree is like it's hard to tell, like if we categorize RSV, rhinovirus as a risk factor to develop asthma, whether it's too early to tell no, COVID was not related. We do get a lot of referrals. They had COVID and then there onwards, they're just reactivity has increased. If you call it asthma for us, reactivity increase means you have a reactive airways or asthma, it's the same thing. But we do have a significant population.
What's the regeneration cycle of the, type 2 alveolar cells?
Pretty
Like how long does it take to come back? Like
yeah, it should not
fast or
take
it
months.
shouldn't take months like
No.
that?
No, it's pretty good. Yeah.
I don't know. Such a basic science nerd, I'm sorry.
So whether that can be a risk factor to develop asthma, I think possibility. It's kind of hard to just tease it out. Because previously we were just talking about RSV, then we included rhino along with RSV to cause asthma.
The classic thing if you have RSV is an increased risk of asthma at some point in your life, maybe 5, 10, 15, same thing.
Yeah.
That's the other good talking point with the vaccines is you brought up the examples of the cardiopulmonary arrest after vaccine, which is probably low, probably 1 in a million or less.
It was just that one case report.
Very rare. And if you look, did someone get cardiopulmonary arrest after riding a roller coaster? Yes. So it didn't to bring it into perspective. And for those who are not vaccinated, the risk of long COVID is about 1 in 20 people get long COVID if unimmunized. If they're immunized, the risk is less than half of that. So that's one thing that is helpful for families to hear when they're wondering, should we vaccinate our child for COVID or not? Most kids don't get hospitalized with it, as you brought up, they do fine. So long COVID is an important piece because it does bring those rates down. And once they have long COVID, we don't have many tools to fix it, so.
I think a lot of the hesitancy is just because of the rapid development of vaccines. It doesn't mean they're less effective or gonna alter your DNA. It's something that I heard a lot. So it's just a lot of reassurance that yes, it was developed fast, but it was also tested. And we have a lot of data to support it.
Is there an emerging seasonality or not? It seems like maybe, but it's just my own perception. I just was curious then, if we're seeing that like influenza. Just curious.
I honestly have a feeling it's gonna be hard to tell because nobody wants to be tested for it.
That's probably true.
That is true.
So we won't. I don't know how many times we've done a COVID test in the last 6 months.
I've done some, but I mean, so there, if you look at the tested positives are up locally. And so presumably that means you quadruple the,
Yes.
quintuple the number of infected cases, but
It's actually people ordering.
at least at the beginning of the season, I had read that basically it hasn't become seasonal yet. They expect it to, but again, COVID's 5 years old, so all of this data is 15 years from now, and we'll say, oh, no, it definitely causes asthma, or no, it doesn't. But I've been here for 21 years, and so if I think about something that happened when I was here for 5 or 6 years and what I'm doing now, it makes a huge difference. And back to the vaccine talk, you could talk about COVID vaccines forever. When I have talked to families about it, far and away, the people who refuse it are refusing it because of the time that it's been out. Because when I talk to them, I'll say, listen, logically, if you get a flu vaccine, you can extrapolate the same logic to getting your COVID. Your risk is low, but it's lower with the vaccine. And they're like, And then if they ask me, well, do you have 15 years of data? No, of course not, because the thing didn't exist till November of 2019 or whatever. So that's, now, someday we may get away from the politicalization of it, and then people will be okay with it, but we'll see.
The other reason for going on is not to get tested is because most of employers have still same policy. You get test whether you're out, and nobody want to miss work. We listen from parents all the time, we didn't get tested because they want to miss work.
Well, and you can test over the counter,
I'm
not
sure
report.
stick ups.
A couple weeks ago, I saw on a social media meeting, which pretty much always live. Because we've got all these millions of people with information about purchasing from the vaccine, which is incredibly false. I don't trust conclusions from seeing something without verifying it myself. So I was cranking numbers during all this. And if you have COVID, you're gonna have some degree of inflammation of the heart. But the risk of inflammation of the heart, myocarditis from the vaccine was 1/10,000th of a percent. Wow. You know, like people say, oh, I don't need, yeah, that's really easy, man. And we certainly saw a lot of myocarditis with it. And that actually number definitely true in South Dakota. I mean, the sickest kids came to us in this area, and we had 6 out of all the hundreds of thousands of people around.
And our asthma population did pretty well with COVID. Remember, 10 of our asthma patients were admitted because they had COVID. But either, you're right, either they were doing things correctly, that happened. Good to see.
Good job.